I left Ian's name on the slide so that we could all remember him for a few minutes. He had a pretty torrid time last night, and he could have arrived just after the end of this talk. That was the first flight he could have got over. So I'm going to talk a bit about NICE fracture guidelines. And you've all heard of NICE, National Institute of Health and Care Excellence, and you at various times we've come across NICE guidelines of one sort or another, and you know that it does actually influence what you do, whether it's for the good or for the bad, but it does have an effect. So it's something that's worth knowing about and worth paying attention to. And it's interesting, it's pretty well respected elsewhere too, so that although it's something that in England we have to pay attention to, in other parts of the world it's referred to because it's a sound source of information, and particularly that it has to take into account the cost effectiveness. So a little bit about what NICE does. I've been involved in two sets of NICE guidelines. The first was the hip fracture NICE guideline, and then more recently the trauma suite, in which there were five components. There was two of those were related to fractures, one called complex and the other called non-complex fractures. And the first time you go down there, you get involved as a clinician and think you're going to do quite a lot, and then you realize how you're in a way straitjacketed by it, but because it's a good system, a robust system, it gives a product which then stands scrutiny from outside. So you start off with a remit. Somebody gives a contract to NICE. In the case of the fracture guidelines, that was the Department of Health. They employ NICE to produce a guideline. Then NICE subcontracts that to a group. In our case, it was a National Clinical Guidelines Centre who produced the majority of the NICE guidelines. They bring together a GDG, a guideline development group, and the first one that Tim and I were involved with, the HIP guideline, the scope was already drawn up before we ever got involved. So the scope is, you get to realise, is all important in these things. It contains fundamentally all the questions that you have. So the question came up as to, when we were discussing before, why in the NICE hip fracture guidelines it mentioned about what implants you should use, but in the BOST it never did. And it was because the stakeholders and the contract placers told us that we had to in the scope. It was a requirement. So the GDG gets formed of a variety of people. We draw together the questions. We make the questions that are going to be the subject to the research reviews by the staff that are based at NICE. There's a draft recommendations come out. It goes to consultation. The consultation is dealt with and it's published. So it's a multi-stage procedure. And so in any one guideline, you can only do about 20 reviews. And so for the complex fractures or non-complex fractures or the hip fracture, there's just 20 questions that you can look at. So it's not like writing a textbook. It's not like writing a BOST where you've got a free hand. There are 20 points that you go for. So what is complex and non-complex? We were given those terms. They were just written, there will be a complex fracture guideline, there will be a non-complex. So we had to make some meaning out of them. And I think it's important so you understand why there are two guidelines. They're pretty continuous, but in broad terms, the non-complex are those that are likely to be dealt with in any of the receiving hospitals, whereas complex fractures require transfer or consideration of transfer to a specialist centre. And then it was further dictated to us that the complex fractures would include pelvic, open fractures, and pilon. So there was no choice about that. And there were other things that we were able to nuance into it, so that we wanted to get other questions to go in there that we thought would help, because from the clinician's perspective, what we thought is this is an opportunity to try and influence things so that they'll change for the better. And so there are general questions that come up relating to the availability of expertise, the urgency of any particular thing, and the system costs that are not just related to one injury. You can use those as a marker, but you want to try and get the best bang for your buck across the whole of the spectrum. And so in the guideline, what we did was instead of having one injury, which we followed all the way through, we picked the injuries that would notionally pave a patient's pathway to the best. So if you're worried about imaging and the relevance of early diagnostic imaging, then it was probably appropriate to look at the scaphoid. If you're worried about timing of surgery, you're going to look at open fractures, or you're going to look at an ankle fracture. So you choose it, and then what we wrote into the introduction, and this is, all these things are quotes from the full guideline, that it was inherent that the guideline whilst recommendations are only made in relation to individual topics, these recommendations should be considered as representative of the management. Here, this was in the non-complex fractures in general. One of the things that came out from the hip fracture guideline was that it was very specific, and people read the guideline and just take what they have to out of it. We were told at the beginning that if you imagine that you're a commissioner, there was a commissioner who sat there with us. If you imagine you're a commissioner, what you're trying to read into it is how little can I spend to achieve this? Whereas as a clinician, you're thinking, how much can we get out of writing this guideline? So there's people with different objectives. So for instance, with the hip fracture guideline, you say in there that hip fractures need an orthogeriatrician. So in lots of hospitals, the only fractures that get an orthogeriatrician are hip fractures. If you've got a fracture a bit further down your femur, you don't get it. That certainly applies in our place. And so that was put in there to try and help with that. We could discuss levels of evidence, cost effectiveness, and the decision-making process, and I've done a little bit about that. But what I rather think we should do is take the guideline that's come out and the recommendations that have come out and just see, do they give us any opportunity, do they give us any leverage for things that we might want to do? Because it's an opportunity that's going to become stale as time passes, so we want to make the most of it. So you'll see in the NICE recommendations that you can have various words, like that came up this morning about consider or offer a treatment. It's very seldom that you can write something which has an imperative in there. And when we got to this, all trusts receiving patients with open fractures must have information governance policies in place to enable it so that you can get a picture of the open fracture without falling foul of legislation. When we started to write this, you get advised by the editors how you can write it, and we were told that must had to go in there. So this isn't advice, this is an obligation. That is now an obligation for trusts to deal with. That's not something that they can question by all accounts. It becomes a legal obligation. And where that was discussed with one trust, they feel that has probably lifted the obligation from you as an individual to them as a trust to have this system in place. So that was the only case where we had something that was an imperative. And it does mean that then you can write the next bit, which is consider, which is a much more loose term. Consider photographing open fractures, because we'd like to do that as part of the clinical component of it, but there was no point writing consider if you didn't have that bit before it, because you couldn't consider doing it at all hours of the clock if there was no system in place. So that was a fortuitous thing, and that's where NICE has quite a lot of power to be able to do that. When Ian was drawing, he sent me his talk, and I've taken things from that. When he was drawing it through, what he thought was that we should look at how time crosses the various areas of the trauma guidelines. So time is clearly important. In elective practice, the time from the onset of the symptoms is not so clear, but in trauma practice, there is a time zero. So you are bound by knowing when the problem started and when you might have to intervene. And you know that where we have had implementation of various practices, the time may be one of the components that helps. It may not be. But in hip fractures, the mortality has dropped at the same time as we've been implementing all the things involved with orthogeriatricians better set up, but time to surgery is one of the things which is considered to be important. So what about time in other areas? So in the guideline, you'll see that open fractures, antibiotics, you give them within an hour of injury. And the implication of that is it will mean that it will need to be considered whether that can be given pre-hospital. Debridement will need to be earlier. Immediate for highly contaminated injuries. It was interesting with the BOA BAPRAS guidelines that came out, that was always the intention. Highly contaminated were dealt with straight away. For the more severe but not highly contaminated ones, so the 3As and 3Bs, within 12 hours and within 24 hours for the others. And if you translate that into what's likely to be practice, it means that if you have a same day, if you have a daytime fracture, then it should be able to go to theatre that day. If it's something that comes in the night, then it's going to go first the following morning, if it's a 3A or a 3B. And for the lesser grades, then they have the same urgency as other fractures that need to go, like hips, like ankles, they should be going the following day. So you need to have a service that can cater with that. And what comes as a corollary to saying that you need to be able to take 3As and 3Bs to theatre within 12 hours, or highly contaminated ones straight away, is that there mustn't be a delay from the identification of it being an open fracture to being in a place where that debridement can safely take place. Hence the guidance that you bypass. So there's immediate transfer of open fractures of long bones, hindfoot and midfoot, to a centre that can deal with them. Because if you don't do that, you're never going to be in a position to achieve debridement within an appropriate time. So when do you get definitive cover? Well then, ideally should be done on an the operation should ideally be carried out on an orthoplastic list. So what's orthoplastic? Well, it gave us the opportunity to write a definition of that and put it in the appendix as to what an orthoplastic centre should be. So it's not just where there are orthopaedic surgeons and plastic surgeons there, but they have to be in a position to operate together, to run joint clinics, and it to be orthoplastic joined together as opposed to orthopedics and plastics at different ends of the same hospital. So it gives you the opportunity to say those things and get them out in the public domain. When should you get definitive cover? Ideally within 72 hours. And when internal fixation is used, perform the definitive soft tissue cover at the same time as the fixation. So what about vascular injuries? Another time imperative. Now this one's already had an effect with us. So the vascular surgeons that were involved were quite clear that what you should be using were hard signs of a vascular injury. So that was lack of palpable pulses, obvious bleeding, expanding hematomas, and such like, not relying on capillary refill or Doppler signals. And then, if you had hard signs of a vascular injury, despite you realigning the limb, then they needed immediate surgery. Do not delay revascularization for angiography. That was and it says in complex fractures because that's the guideline it was in, not because they're particularly awkward fractures. It's not, complex doesn't mean awkward, it means this is in the complex fracture guidelines. So that there's a little bit of wordiness that comes in from NICE each time. But then the bit above, in people with devascularized limb, use a vascular shunt as the first surgical procedure. Who can use a vascular shunt? Who's done it? Well, this is interesting, you see, because it's not very many. So I went to find out, to learn, and it's remarkably straightforward. If you've got the right people there, it's terribly quick. I went in to see the vascular surgeons doing their carotid surgery, and they shunt it with the patient under local anesthetic. It's quite extraordinary, the ease with which they can be put in by somebody who knows what they're doing. So you can shunt and restore continuity very rapidly, then you can restore mechanical stability, then you can get the soft tissue cover. So on the back of this, we're running our first in-house course to teach ourselves in Oxford with our vascular, our plastics and orthopods to go and play on cadavers, just so as we familiarize ourselves so that we know on the day how we're going to do it. We're going to rehearse it. But it's because we've been prompted by this, which is quite sound. I mean, I knew what it was writing, so it was good. Another time-sensitive thing, it was very interesting. I don't know how many were here when John Etherington spoke this morning about rehabilitation, because I knew what we'd written in the NICE guideline was that amputation is you do it immediately if it's life-threatening or the limb is definitely not salvageable. But then there was the question that had come up about what are the problems with delay. So we had what this means in here by delayed primary amputation. I didn't copy the definition across because I didn't realize what John was going to say. But it's if there's going to be a relatively early amputation, so if there's going to be something in the first few weeks, you need to do it within the first 72 hours. And so that's different from what he was saying about it doesn't matter in terms of function if you wait for 18 months after a failed attempt at limb salvage. This was all to do with the evidence associated with increased infection rates if you delay the primary amputation. So what's said there doesn't contradict what he was saying. There is a definition of what delayed primary amputation means. So I'll just move away from complex fractures a little bit because it all comes under the heading of timing of surgery. So fractures that don't have a time associated with them have no priority in the system. So a number of the stakeholders at the beginning in putting the scope together had noted that things like a distal radial fracture or an ankle fracture, if it gets put on we'll do it as soon as there's an opportunity list, that opportunity may not come up forever, basically, and there's no pressure on the bed managers to get you the bed because there was no limit put onto it. So that was why the question came up, and then it became clear that the recommendations could be more straightforward. For ankle fractures, you should do them early. And for distal radial fractures, because the draft guidance, which influenced the choice of operative management, was for closed procedures, then you needed, if you were going to try and reduce an intra-articular fracture, deal with it early, and that needed to be soon. And with an extra-articular fracture, there was a longer period of time. But there was an end point for each of these people. So this was a lever, which I think we hope that will help the patients that are there. Just a couple more things to say, a couple more that came out of it. So we were obliged by the scope to say something about documentation. And the documentation discussion then became really quite interesting as to what you should produce and the various parties there as to what they wanted. And so I think this is quite a sound advice. So produce a written summary which gives a diagnosis, management plan, and expected outcome, and is aimed and sent to the GP within 24 hours of admission, includes a summary written in plain English that is understandable by the patients, family members, and carers, is readily available in the patient's records. And the key thing in there seemed to me that it meant that within 24 hours, somebody ought to know that. Because a lot of people are in hospital at the end of 24 hours, nobody actually knows that. Nobody's formulated that in their mind. But it will prompt us to do that. And it's something that we can be questioned on, because one of the things that will come from this is when we get inspected for various things, documentation will be looked at, and what is the quality of your documentation? Do you comply with this? At the end of the first 24 hours of a patient's admission, is there something rational written about their plan in plain language that a GP could understand? So that was all I was going to say at this moment, because I think there'll be questions coming in related to it. But the prime thing that I think that I would like that you take away from looking at any of the guidelines that you have is not to look back as to how they were formulated, because at the moment that's done. And if we do that and look back and argue about the mechanism by which they arrived, we lose the opportunity and the leverage that they give us at the moment to try and change things for the better. Because I think that within the guidelines there are a lot of opportunities actually to improve the system. Thanks very much.
Thank you, Bob.